This episode of Pupil Pod is supported by Dompe.
Welcome to Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Sila Bal, and my guest today is Dr. Ike Ahmed. Dr. Ahmed probably doesn't need an introduction since many of you have heard him speak and or follow him on social media. Dr. Ahmed is a glaucoma and complex anterior segment surgeon based out of Toronto, and we are very lucky to have him on the Pupil Pod today. Dr. Ahmed, thank you again for joining me.
Hey, thanks so much, Sila. It's great to be here. Looking forward to this. Congratulations on putting this together. I think it's a great opportunity and looking forward to this.
Me too. So let's get right into it. You are taking care of a 68-year-old man with a history of primary open-angle glaucoma who is on maximum medical therapy and now has progression of his visual field defects and glaucomatous optic neuropathy. Dr. Ahmed, when do you decide to move forward with incisional surgery in patients such as this?
Yeah, this question's become more complicated with the advent of newer procedures that we have available, including MIGS and less invasive surgery. But in general, it's for patients that are either progressing, patients who are on maximally tolerated medical therapy who are above their target, and typically reserved more for patients who have more moderate to severe disease, where really the window to preserve vision is shortened. And so those are the primary indications. Of course, angle closure is a little bit of a different boat. Angle closure, we typically look to intervening earlier just because it's such an anatomical problem. But those are generally some of the indications. And I will add one more thing, is when a patient's going to cataract surgery, in the past, that was a primary focus. But now with MIGS, we often combine cataract and glaucoma surgery, even if the patient's not progressing or has elevated pressure, but more so to reduce the medication load.
Yeah, I've been starting to see more combo surgeries. Obviously, I'm a second year, so just starting to see those surgeries. And it's really incredible that we're able to do those surgeries at the same time and that we are having some good results. What are the relative contraindications to trabeculectomy and the factors that increase the risk of bleb failure in these patients?
Yeah, I mean, this is always a challenge we're dealing and fighting with wound healing. And so there are eyes that have a higher risk of scarring. Certainly patients who've had previous surgery already that's failed, people who have previous conjunctival surgery or trauma. There are certain conditions, of course, like neovascular glaucoma, uveitis, some of the secondary proliferative glaucomas that have a higher risk for failure, like ICE syndrome would be one. And then, of course, there are certain racial and other demographic factors. Patients who are non-Caucasian have a higher risk factor for failure, and people who have bad ocular surface and the sort. So anything that really is going to affect conjunctival healing would be patients who would have a higher risk for failure in any bleb surgery, trabeculectomy, or any form of diversion of aqueous in the subconjunctival space.
Yeah, I do remember on my glaucoma rotations, the attendings were so adamant about taking care of the conjunctiva and making sure that the patient has a healthy conj. One of the things that we think about a lot as residents, and obviously as a glaucoma surgeon, you think about is the difference between limbus-based and fornix-based approaches for TRABs. Can you walk us through that? Because I think that this is a little bit confusing for the residents.
Yeah, I mean, it's interesting enough that, in the past, this was more of a debate. I will say nowadays, we have really all generally moved toward fornix-based surgery, although there are some surgeons that still prefer limbus-based. And the best way to think about it, limbus-based, is basically that the base of the flap is at the limbus, and the fornix-based, the base of the flap is in the fornix. So for limbus-based flap, of course, one has to make an incision fairly posteriorly to the limbus, 10 millimeters back, for example, and technically the access can be more challenging. The advantage is, however, though, that things like incisional leakage and dehiscences are less common. But the disadvantage is, though, now you have this posterior limiting scar. And we're all trying to get this diffuse posterior bleb forming into the quadrant. And that posterior scar can limit that. It can lead to more localized bleb. Fornix-based flaps are technically easier. We're just cutting at the limbus, doing a localized peritomy, and the flap is raised, and we have access to sclera. We don't have to worry about moving the conj away from our incision site. So technically, it's an advantage, and we reduce the need or the concern about having a scar posteriorly that could basically block flow posteriorly. The disadvantages are at the limbus is that you may have more a higher chance of having an early bleb leak. And so closure is very important, and we all have developed ways to do that. It's always important to remember that with any bleb, of course, we try to position the bleb in the superior quadrants. We avoid inferior blebs for risk of endophthalmitis. And I think really the application of mitomycin C is probably even more important in terms of obtaining a nice, ideal, diffuse, non-cystic bleb.
And that is a great segue into our discussion on antifibrotic agents. But I just wanted to stop for 1 second because something that you said just really made it click for me, because I was getting confused. And I know that a lot of my colleagues were getting confused about fornix versus limbus based, because you always think about things in terms of where the incision is. But when you put it as where the base is, that actually makes a lot more sense. So you think of the base as at the fornix and the base as at the limbus, and that helps you to figure out which one is which. Because for me, it was always like, oh, limbus is opposite. You don't cut at the limbus, you cut away from the limbus. So I think that was a really great way for me, at least, to understand it.
Exactly.
But getting into the antifibrotic agents, how do you use those in your practice?
Yeah, I mean, nowadays with glaucoma surgery, you wouldn't imagine doing filtering surgery without antifibrotics, antimetabolites, because the issues around wound healing are enormous. And this is increased with the advent of medications, because medications themselves can cause conjunctival toxicity even without other known risk factors. So, I mean, we use it all the time. And, there are two options that we typically use in glaucoma: 5-fluorouracil and mitomycin C. I'm sure people have heard these, and they're used in other procedures as well around the eye and also outside the eye as well. The main difference is this: 5-FU is a weaker agent. It's a pyrimidine analog that selectively affects the active phase of the cell cycle. So basically, it inhibits the proliferative phase of fibroblast proliferation and migration. And so, it works specifically only on a certain part of the cell cycle, while mitomycin C is a very strong alkylating agent and cross-links DNA within cells. And it really, is independent of the active phase of the cell cycle. And so literally, it really just kind of nukes the cell, in other words. So it's much more powerful. In fact, in current doses we use for the eye, mitomycin is about 100 times as potent as 5-FU. And for that reason, we did typically use it intraoperatively. 5-FU is used less intraoperatively, and we typically use this postoperatively when we feel the bleb is maybe at risk for failure because of thickening or vascularity. Now, when we use them intraoperatively, mitomycin or 5-FU is typically applied either by sponge or pledgets, ideally like a Maricel sponge that's non-fragmenting, or can be injected. And we've seen a movement in the last decade or so, including here, that we've typically gone to injections because we have a controlled dose, and the concerns around injections were relatively unfounded in terms of complications. And so I do like to do this by an injection, although certainly sponges have been the norm traditionally. And typically, if you're using a sponge, you're doing it for a certain amount of time, and most would do some irrigation after the application. When we're doing a postoperatively, of course, we typically do a transconjunctival injection into the area of the bleb, and that's something that we typically use with 5-FU. And one last thing is that we do use them for needling procedures. And later on, if we have to do a needling procedure, then the antimetabolites are useful. I typically use mitomycin C. I want to get a strong, effect, but some people use 5-FU. And 5-FU typically is a standard dose, typically 50 milligrams per cc at whatever volume you put in. Mitomycin C, I should have mentioned earlier, we do vary the concentrations, 0.2, 0.4, 0.5% are commonly used, and we may vary the amount of time the sponge is used. So you can imagine there's lots of moving parts in here, and very much it's a personal preference. And of course, if there's a higher risk for failure, we may use a higher concentration or higher application time.
Great. That was actually extremely helpful. So you kind of touched on a couple of these complications already when you were talking about needling and post-op bleb failure, but what are some complications of TRABs?
Well, there's a long list, and that's one of the reasons that's really, prompted us to try to do better from TRABs. But basically, we can think about early things, things like hyphema, wound leak, and of course, issues around healing. Things we worry about anatomically are hypotony and shallow chambers, which can lead to effusions and choroidals, which is a concern, of course, and also malignant glaucoma that can occur. So those are some of the things we worry about early on. Later on, probably the biggest things we worry about beyond failure is the risk of hypotony and bleb leaks, and also endophthalmitis related to that as well, and chronic hypotony. So those are some of the concerns. Studies have also shown that trabeculectomy with application of mitomycin C and antimetabolites do increase the risk of cataract. surgery is often required in patients who are phakic. So, those are some of the big ones that to think about. Of course, there's smaller ones like foreign body sensation, ptosis, diplopia, ocular surface issues that can be chronic and irritating as well.
And in which patients would you actually think about considering a tube shunt rather than a trabeculectomy?
So yeah, Sila, we've got more data on this from the TVT and PTV trials, which are both trials comparing trab versus tube, either in refractory glaucoma, meaning patients who had previous surgery, or patients who have not had previous surgery as a primary therapy. And basically, traditionally, as expected, we typically look at places where where trabs may fail. So we mentioned earlier neovascular glaucoma, uveitis, eye syndrome, things like that. Certainly, patients who have bad conjunctiva or patients who have failed previous filtering surgery will be candidates. Patients also where maybe you're worried about an anterior bleb, like a contact lens user, would be a concern. Many people also look at aphakia, or patients who've had previous multiple surgeries because the eye is, of course, had a lot of surgery and more risk for scarring. And in fact, the TVT trial did show that in eyes with previous intraocular surgery and filtering surgery, the Bearvelt implant had a higher success rate over 5 years than trabeculectomy, even though early on trabeculectomy had lower pressures and medication use, hypotony and other risk factors led to more failures with trabs. Now, however, for primary procedures that aren't high risk or haven't had previous surgery, trabeculectomy is still king. And so there's not necessarily a lot of reason to move to tubes as first line for most cases, but certainly as a second line or refractory line, I think tubes have become more common.
Since we have to be a little more cautious with tubes, are there any contraindications to tube shunts?
Well, there's a couple of things. I mean, tubes have some unique complications, and they include diplopia, erosions, and corneal endothelial dysfunction. So patients who really, really have bad conjunctiva, even patients with not two trabs on, we got to be careful because if the conjunctiva is in poor shape, we may want to avoid that quadrant because tubes can erode. Patients who have had again major buckling surgery or sponges placed posteriorly where we can't put a tube in that quadrant. And then, of course, patients who have, for example, a very, very shallow chamber where you can't put the tube in, and you maybe you haven't removed the lens, or patients who have corneal endothelial dysfunction and evidence of borderline function, where we worry about the presence of a tube may tip the patient over. Although I do say again in those cases, sometimes we still have to bite the bullet. And as I often bug my cornea colleagues, I always say that the corneal endothelium can be replaced, but the nerve and RGCs can't. And so in those situations, we still sometimes have to go to a tube.
I love that. I think that every service always thinks that their specialty is king, and everyone makes a good argument. As a resident, you're like, yeah, of course you can't replace the optic nerve. What would you do without it? And then retina colleagues say the same about the retina. What are the complications of tube shunts, and how do we prevent or manage some of those complications that you would see in your office?
Sure. I mean, so just to go through some of them, I mean, most of the trab complications can also happen with tubes. So hypotony, shallow chambers, choroidals, overfiltration, failure, those can all occur. There are certain things that are perhaps more or somewhat unique to tubes. They include, for example, erosions that can happen over the plate or over the actual tube. In those cases, we want to make sure that, of course, we properly cover the tube, typically with graft material, and close conjunctiva adequately. If there was an erosion, then we would typically look to cover the tube again with another graft material. Typically, I use sclera personally or pericardium, and also close with good conjunctiva with perhaps a rotational flap. Tubes can get blocked. They can get blocked by blood, pigment, fibrin, things like that, and that may require an irrigation or the injection of TPA. The tube is embedded in the iris. It needs to be kept away, and of course, maintaining a bevel up position and away from the iris is important. And then, for diplopia and things like that, those are sometimes hard to predict and hard to avoid. But in scenarios where it's a problem, we often have to go to more complex surgery to resolve the diplopia. As far as corneal issues, it's important to keep that tube away from the cornea. I like to place it quite deep into the anterior chamber. If the patient's pseudophakic, we often put them in the posterior chamber in the space between the lens and the iris and the sulcus to keep it away from the cornea. So those are some of the unique considerations for tube shunts and how we can prevent or manage them.
Okay, thank you. Now, I think that this gets us to one of our final topics, which is what I think to be the most exciting thing about glaucoma surgery, and that is all of the new minimally invasive techniques. Can you tell our listeners a little bit about how these techniques work in general?
Yeah, I mean, this is super exciting and it's changed our field. I mean, we have become, much more interventional and treating patients earlier because we realize the problems around drops and compliance and fluctuation. And so, we can talk about MIGS, and MIGS are more physiologic procedures directed toward the canal and the conventional outflow or suprachoroidal space. And that's kind of what I call MIGS. People often talk about some of the newer bleb surgeries, like, for example, some of the microshunts and microstents as MIGS. I try to put that under sort of a category of subcons surgery or subcons MIGS, or lately I've been calling it MIBS, minimally invasive bleb surgery. It doesn't have the same ring as MIGS, but kind of give the idea about the differentiation. Now, in terms of MIGS, basically, that's typically patients who are looking more for modest targets into the mid-teens, more as patients who are, an alternative to medications. So these would be, example, early mild to moderate glaucoma, typically open-angle glaucoma, often combined with cataract surgery because we're already in the eye. Let's get patients on less medications and have a better ocular surface as well. And that's kind of the category, although we do use standalone MIGS as well in patients, for example, who again are typically high pressures but are not severe glaucoma that can be satisfied with a more mid-teen target. And then we use some of the minimally invasive bleb surgical techniques as an alternative to trabeculectomy, or even using it earlier in trabeculectomy because the control of hypotony prevention, and more posterior flow, and again, doing it with a small form factor compared to tubes are beneficial. I kind of look at those procedures as kind of the best between trabs and tubes. They got the safety of tubes in many ways, but with the efficacy of a trab. And that's kind of where we're going with microstents and microshunts. So that's a lot to talk about, but that's briefly kind of what we think about. So really, in my practice nowadays, trabeculectomy is less commonly performed. We do combination cataract MIGS a lot, and we do a lot of standalone minimally invasive bleb surgery a lot before we move on to trabs and tubes.
Great. Thank you so much. That was a really comprehensive summary. So, just to summarize for our listeners, trabeculectomy is reserved for moderate to severe open angle and angle closure glaucoma that is refractory to medical or laser management. The limbus based approach is actually closer to the fornix, is technically easier, and has less wound leakage, but has a bigger bleb. The fornix based approach is closer to the limbus, technically more complex, has more wound leak, but creates a flatter bleb. Tube shunts are for patients that cannot have a trabeculectomy, such as those with a failed trab, neovascular glaucoma, or uveitis. MIGS shunt aqueous from the AC directly into Schlemm's canal or into the suprachoroidal space. And as we just learned, there are many different categories that we can use in our practice. Since this is a two-part episode, I'm going to save my question until the end of next episode. Dr. Ahmed, thank you again for joining us for this episode and for the next episode. We've already learned so much about glaucoma surgery and minimally invasive glaucoma surgery, and I'm sure our listeners are excited for our laser topic.
All right, we'll see you there.
And thank you to our listeners. See you next time on the Pupil Pod.